next speaker is Dr.Jiri Dostal. Dr. Dostal is a medical doctor specializing in cardiology. We met at an ACSM event shortly after we launched the Moxie. I believe that was either 2014 or 2015. And he's been a strong advocate for the technology ever since. He works with athletes ranging from youth through professional level in a wide range of sports. I know he's worked with hockey players and cyclists and other sports as well. And he's in the Czech Republic in Prague. His presentation today is muscle oxygen data to diagnose iliac artery syndrome in competitive cyclists. And I have to note that Moxie is not a medical device, but this is an application that probably can be used prior to medical treatments. And with that, I will say take it away, Dr. Dostal.
Okay, so once again, welcome everyone. I need to apologize for the technical troubles at the beginning. However, I would like to show you as said before, Moxie is not a medical device, but what we have tried to use it as a functional diagnostic tool. And at the end of the presentation, you may find out how even a non-clinical person can help the clinicians in terms of the assessment of some of the most frequent cycling issues. First of all, I'm presenting here on behalf of me and my colleague. We are from Center for Sports Medicine in Prague, and we are also a service center for the Czech Olympic Committee. Before we actually start, we should have been right now sitting in a rowing club on the beach of the Prague River. However, and Roger, Roger said something about the Pilsner Urquell toast, but I want to show you actually we are not a country of the Pilsner Urquell only. We actually do have something which may actually offend the U.S. people which believe that Budweiser is actually a U.S. beer, but I want to show you that Budweiser actually comes from somewhere else.
This is definitely different than the Budweiser commercials we see during the Super Bowl in the U.S.
Absolutely. So let's go to the real world, and I want to show you because I assume that not everyone in the auditorium comes from the cycling area. So I want to show you something about so-called iliac artery syndrome. The iliac artery syndrome is something which is pretty common, especially in the elite cyclists. It's about 15 to 20% of the left leg pain, mainly elite cyclists, comes from the iliac artery syndrome. And what it is actually something. Hold on a second. Not sure you see my pointer, but
we do see the pointer, so you can use that.
Good, perfect. So simply, mainly it comes from the long tortuous iliac arteries, also hypertrophic psoas muscle, and which actually during the hyperflexion on the bike, actually it creates, for example, kinking, and it ends up with the endofibrosis, which is much thicker arterial wall, that creates a stenosis after that. It is very asymptomatic, which means there are no significant issues at the low cadences or a low power output. While, however, when it comes to the really submaximal or maximal power output, then it actually comes with a typical claudication. The claudication is pain, which is connected to the power output. Sometimes a muscle cramp, limb pain, and usually the thigh is actually rather affected than the buttock. So the current diagnostic and treatment is very actually typical for any other silk artery disease. We are using so-called ABP index, which is a specific protocol that we need to use, and we simply measure the pressure in the distal part of the right and left leg. But this is very unspecific and very basic one. For the ultrasound, for the external iliac artery and common iliac artery, the sensitivity is extremely high. It's extremely wide. What I want to show you right on the right side, on the right side of the picture, what you can see clearly, this is a stenosis. This is the CT angio of one of the affected cyclists. What you see, if you compare the right iliac artery, you see a very nice structure. While on the left side, you see hooks, you see significantly affected areas. And this is called external iliac artery, and this is common iliac artery. And what you see that in the ultrasound, which is available in a many of the sports medicine clinic, the sensitivity is pretty good for the external one, which is that area going straight to the limb. However, for the common one, which is more inside, deeper, the sensitivity is extremely low. The CT and angio and the MRI angiography, could be theoretically great. However, once again, the sensitivity is extremely wide, and the reason is that you simply have a guy. You need to put him into the hyperflexion and then you can the hyperflexion is like a cycling seating while he's lying on the CT, or sometimes in the MRI, which you can imagine sometimes it's simply impossible. So that's why it's so huge variation. And as you see, all of those are morphological. So there is nothing the ABP index is a little bit in terms of functional assessment, but overall it's about the morphologic one. And for this moment, there is only one approved causal treatment, which is a surgery, and I show you some of the pictures we have. So I want to show you. We have got some guys, but I want to show you one typical example. We have a 23 years old guy. He's a pro cyclist, and he has 2 years of history of progressive left leg pain. And the ultrasound shows a really asymmetric stenosis. Asymmetric means the stenosis looks completely different from different angles. Depends on how you cut with the ultrasound picture of the artery. And then the CT angio shows exactly the borderline, common iliac artery, and about 45% of the external one. There are different approaches for the so-called severity and the decision whether to operate or not. So there was a question mark, should we operate this guy or not? Because the pain was borderline. Actually, the pain was somehow severe, but as you see the pictures and the results from the CT were questionable. The ultrasound was also not clear how to approach that. And then if you remember from the last slide and I didn't talk about specificity, only the sensitivity, as you see. was questioned. So we end up, to thinking, okay, how we can help this guy, and we came with the hypothesis. So simply because if we know that if in terms of muscle oxygenation, if there is a correlation between the clinical symptoms, which is a pain, and the difference in the muscle saturation, we simply have a proof that the pain is caused by the difference in the in the blood flow. Because if we assume that both legs have the same muscle oxygenation or oxidative capacity given the long training status and the cyclists, then definitely the difference in the muscle saturation needs to come from a different flow and reduced flow on the left leg. The similar principle is so-called functional fractional reserve, which is used in the cardiology, in the intervention cardiology. You simply measure the flow or the effect of the limited flow after the distal part of the stenosis. So what we did, we exactly used the same principle, and we look at the reference is either the unaffected leg, and then in case we decide to go to the operation, we want to see the difference between the right and the leg. We have had this discussion, how to approach that from the ethical point, because this is not a medical treatment, this is not a medical diagnostic tool. So we discussed with the guy how would we approach it, and he signed immediately informed consent that we simply told him, listen, this is an information that for this moment you will, we have no other option how we can get this information, and he agreed, and then we agreed that we will make a decision after that. So the methodology was actually very simple. We know for this moment that typical ramp tests doesn't work well in the diagnosis of the iliac artery stenosis. The reason is very simple, because you need a certain ischemic time to be able to produce the clinical symptom. So the regular fast VO2 max or sometimes the lactate test doesn't work enough here. So what we did, we took a typical time to exhaustion test. When we told him, listen, I want you to bike on the cadence and the power that would be leading to the clinical symptoms. And I will show you what were the results in the next slides. Then the second thing, we find out that we need to control the output, because naturally, of course, he would be, as the pain would progress, he would be easing the working on the left leg compared to the unaffected leg. So we instructed him to really make sure that he has the equal power. We said 48% minimum and 52% on the right and left leg, and we use a watt bike, which is a great tool to be able to compare both legs and right and the leg. And then we put simultaneously 2 moximeter on the mid portion of the rectus femoris. Now, we know that in typical place is the vastus lateralis. While we put the rectus femoris is very simple. When we have a pro cyclist, we saw one thing: with high increasing of power, the activation and deoxygenation of the vastus lateralis is actually linear, while the deoxygenation of the rectus femoris is the exponential. As we wanted to see as big difference as possible, we decided to go to the rectus femoris. And of course, the simultaneous recording via peripedal software, because this is the only thing which works for this moment. So here's a procedure, and we recorded a short video that is very instructive, so you can see it pretty well. So you see, hold on a second, I stop it. I will return it back. So what you see here, you see a Moxie on both legs, right and left. And I see it, I stop it. So what you see clearly on the upper part of the screen is the right leg. On the left one is the left leg. You clearly see, you don't have to be a rocket scientist to see one thing is a completely different pattern on the right and left leg. You see that we started in a 4 minute before it was a calibration period to have a SMO2 stable, and then at fourth minute we started in about 450 watts roughly. I will show you the results in one of the following screens. And then what you see, it took them about 2 minutes, the same deoxygenation, while on the unaffected leg was actually a higher oxygen delivery, while on the other one, on the affected one, on the left leg, was clearly a signal or sign of the limited oxygen delivery. Oops, sorry, look. I will stop it to show you. Okay, it doesn't work. What would you have seen was where the numbers that in the affected leg, during the recording already, the right leg was around 70% of the of the muscle oxygenation, and the left leg was about 45%, which was somewhere around the mid of the exercise. And here you have the results. While the right leg was 127, the left leg was 122. Keep in mind, this is a right to left balance. So total work was 250 watts. So if someone would measure, the wattage output, then you would be 249 or 250 watts. And the difference you see clearly on the upper part of the slide. What you can see, this is the right leg. You see a clearly stable muscle saturation that reaches around 70%, while we started around 78, 79. While the affected leg, we started somewhere around 78, and then it ended up somewhere around 35 to 36%. The difference was pretty astonishing for us. For the left leg, the decrease was 45% point in the absolute numbers, which was in fact 53% of the relative number, while the unaffected leg was very stable in about 10%. So then we had a discussion with him, and he agreed, and then he underwent the operation. Just to show.
Dr. Dostal, sorry? we've got about 10 minutes left, so just
okay. I'm okay. Thank you.
Right.
Yes, yep. Perfect. So here, what you can see, those are the pictures taken during the operation. This is the iliac artery, and what you see, how thick is the wall and how small is the lumen inside. So all the yellow stuff is something which was extracted by the vascular surgeon, which is a fibrosis tissue. And when he cleaned it up, the artery looked like that. So you see clearly the difference. Here you can see how much affected was the artery was. And then when he recovered, we put him on the test once again. So we did exactly the same protocol like we did before. He went slightly below in the output, which is non-significant. The reason is because the watt bike is for those who doesn't know watt bike, this is not something that you set up at 250 watts and and it works for 250 watts. While this is a bike that really mimics the regular ride. So you need a pretty well-educated and skilled person to maintain the power while he was, because he's a pro rider. And you see the difference. If you remember those two before, this was unaffected, this was affected leg. So you see difference. And here after the operation, both of them are very similar. So the summary, I have to say one thing. I have shown you one guy. We have got others as well, but they are not so much instructional for this moment. So I decided to show you just one example that is very instructional. And despite of the fact that the Moxy is not a medical device, it can help us to differentiate with a functional assessment whether there is limited blood flow, macrovascular limited blood flow. I mean anywhere, especially in this particular case, in the affected leg with the arterial stenosis. Of course, I mean this is not a study. By the way, it's not a by the way, but mainly my call is also about the call for the cooperation, because it looks like there is a bunch of people, and you see it's quite often in the media, that there are guys who are affected by this disease. However, we have a great group of people in this moment, in this conference, that I believe the cooperation and something what Chris Cooper said before as a call also for the cooperation, I would like to call as well, because this is something that can be a great work and can help everyone in this group. So in my last slide I have my contact details, and Roger have the same information as well, my contact details. I would be extremely interested to start working with anyone who has the access to those guys. And I've been thinking more broadly about that, because usually the doctors see those guys quite late. Those guys usually come from the testing center or cycling center or performance center, but first. And they suffer, and they claim to the exercise physiologist that there is an issue and they feel the pain on the left leg, mainly on the left leg, and there are certain things. People are usually sent to the physiotherapist. They check their bike fitting, they check their body posture, they check many other things, but in many cases this is really forgotten. And the exercise physiologist or coach can help a lot, just simply putting the Moxy on the leg, on the right leg, left leg, let him bike and see the difference. And if there is a difference, there is probably the limited flow, and then from there, the person can be sent to the appropriate deeper screening and the medical check. So where I see a huge opportunity for everyone involved in the NIRS area, in the practical field, that simply this is a tool, even non-medical device, it can help direct the differential diagnosis thinking about the potential affection of the iliac artery syndrome in the cyclist. So thank you very much for listening to me, and yeah, I'm ready for the questions.
Thank you very much, Dr. Dostal. It was a great case study presentation there. If anyone has questions, please type them into the questions panel. We have a comment from one user. This is Jim Arnold. Says, just a comment for Dr. Dostal. I have iliac artery endofibrosis and recently had surgery to repair it. I've used Moxy extensively to evaluate differences pre and post surgery. I'm currently writing up a case study on myself. we'll have lots to talk about offline. So clearly this is a condition that other cyclists are observing as well. Do you have any idea what percentage of cyclists actually suffer from this issue?
There were different studies. Because it is simply actually not. For this moment, there are different numbers because the big question mark, who is a cyclist? When we look at usually this affects a cyclist that are serious, and usually those guys who are riding over 15,000 or close to 20,000 may be affected. And out of those guys, there are different sources report different numbers. Some of them low single digit, 5 to 10%. Some of them are higher. It also depends on on one thing, which we believe this is highly underreported. So my estimation is somewhere around 5 to 10% of the pro cyclists can be affected. There is one thing which we need to be careful about is that severity. We have around another guys who has the stenosis, but at the level of 15 to 20%. So the question is, this guy does not need an operation. He is observed. He is a world tour rider, and we just so the question is, and if he would not come to us just and because we are specialists on that, so we do ultrasound on the left leg almost to everyone. So he would leave completely underdiagnosed. Nobody would even think about it. So my qualified estimation is somewhere around 5 to 10% of the pro cyclists, and it may up to maybe 15, maybe 20%, but not diagnosed and not severe.
Okay. Thank you for that. The next question, is it possible to do the same test with only one Moxy?
Honestly, theoretically, yes, but you will be definitely losing information, and you definitely would limit yourself in terms of the accuracy and comparison and timing. So I would think I wouldn't do it. This is my personal view. But of course, if I would be limited just to one, of course I would do something. But okay. I definitely would try even to rent a Moxy for that test to do it simultaneously. Because okay. The issue is that you need to make sure that you have the same activation on the right leg and the left leg at the same time.
Sure. That makes sense. We'll take one last question here and then we'll go to the break. Are there good values for normal asymmetry?
Okay. We usually have around those 10 to 15% or up to 20%. Once again, it depends on the muscle you use. Vastus lateralis is more equal, while the rectus femoris is more sensitive to the percentage to the higher percentages. And the second thing which we did not look at, and something that maybe the following speaker can talk, because he is a coach of the Czech national team for track cycling, is the right to left balance, natural right to left balance on the process of the professional cyclists. So this is something that we didn't look at that definitely will have an impact. So one thing is the physiological feedback, which you have from the Moxy, which, as I said, those 10 to 15, maybe 20% difference. 20 difference, it means not percent point, a difference itself. And the second thing is the asymmetry on cycling revolution and bike and cycling itself as a biomechanics.
Okay. Thank you so much. That was an excellent presentation. Really appreciate you sharing that data. I think that's a pretty hot topic for everyone.